Hello and welcome to my presentation on hypertension. My name is Lloyd Pate. I'm a clinical associate professor at the University of Houston College of Optometry. This presentation is not affiliated with the university in any manner. It is an individual endeavor of mine. But I do have our mascot Shasta there staring at you. So I just put her up there because I like her. But again, there's no affiliation with the University of Houston. I've included my cell phone number and my email address here. So if you ever have any questions about anything on patient care or anything, just contact me and I'll do my best to help you out. What I would like to cover in this discussion of hypertension is how to properly measure a patient's blood pressure and minimize errors so we get an accurate assessment. What the diagnosis of hypertension is based on, so how we can diagnose hypertension in our patients, and what to do with a patient that we find extremely elevated blood pressure in. When is it an emergency that needs to go into the ER that day, and when it is just an urgency that can go to their PCP in a day or two. So one thing you need to be aware of is the prevalence of hypertension. What's the risk of our patients having hypertension when they come into our office? So this graph is from the National Health and Nutrition Examination Survey from 2015 to 2016. And it breaks down the total prevalence of hypertension in patients 18 and over, and in the age group 18 to 39, 40 to 59, and 60 to and over. And it also gives it by gender, the prevalence for men and women in those age groups. So it's pretty interesting that you can see for men, even for patients below 40, we still have a 9% risk of a patient having hypertension when they come into our practice. By the time they reach the age of 40, there's a 37% risk of our male patients having hypertension, and 29% of our female patients will have hypertension. So those are pretty good odds. 1 out of 3 patients over 40 is going to have hypertension. And that's why in my practice, I arbitrarily screen every patient over 40, well, 40 and above, or if they have a family history of hypertension or personal history of hypertension, or if they're obese, since there's a high correlation with hypertension and obesity. And some things to think about why we need to control hypertension in the population is uncontrolled hypertension is a leading cause of heart disease and stroke. It also raises the risk for kidney and heart failure. I don't know about where you live, but here in my area, you drive along and there's dialysis centers all over the place. And one of the things driving the proliferation of those centers is hypertension. And so, as the data previously showed, 1 in 3 US adults, about 70 million people, has hypertension. And almost half of those people don't have their blood pressure under control. So that's important for us to monitor them and send them back to their PCP if they're out of control. And 13 million US adults have hypertension and do not even know they have it and are not being treated. And so most people with uncontrolled blood pressure have health insurance and see their provider at least twice a year, but still remain undiagnosed. And so we can help pick up undiagnosed cases of hypertension in our office. And so one of the first things you need to know is how to properly measure blood pressure and know some of the common causes of errors in your reading. So this is a little table here with just a few of the more common causes of errors in blood pressure measurement. And I will go with several different slides showing you some of the common sources of error. And this is, you can see the journal here in Hypertension, published 2016, December 12. But you know, bladder distension can cause an false elevation of up to 33 millimeters on the systolic and 18.5 millimeters in the diastolic. And so do you have your patients make sure they've gone to the bathroom before you take their blood pressure? Look at cold exposure. So do you keep your office real cold? Do you let your patients warm up when they come from the cold? And white coat effect, that is a actual phenomenon. And so you also not only have environmental factors with the patient that can influence your reading, but your actual instrument can throw your readings off. There's inaccuracies in all models of blood pressure measuring devices. And so this gives you a little bit of thing on what some errors can be in the different models. And when's the last time you calibrated your blood pressure monitor? So even the mercury blood pressure measurement devices need to be calibrated. You can be quite a bit off just from miscalibration. And insufficient rest period is something. You should let your patients, they were walking into your office, getting there. You actually should let your patients rest about 5 minutes before you take the blood pressure. But we'll get into more about the rest period, body positioning, and all of this. And so you can sort of look at this and see, okay, what am I doing wrong? What can I do better? Because I find that this information here doesn't seem to be widely disseminated among optometrists. Like how many of us have a variety of cuff sizes in our practice, have the small, medium, and large cuffs for our different size patients. But if your cuff is too small on a larger patient, you can, again, artificially inflate the blood pressure, or you can get a falsely lowered blood pressure measurement. And again, some more errors, taking it over the clothing, putting your stethoscope under the cuff so the cuff holds it in place, even talking while you're doing the measurement. So there's a joint collaboration between the American Heart Association and American Medical Association coming out with a project called Target Blood Pressure. And that's because nearly half of the U.S. adult population has hypertension. And again, because of the high incidence of undertreated and underdiagnosed blood pressure, they're trying to make an initiative where patients will get their blood pressure checked at every visit for different health services. So we'll go in a little bit more detail now. We had that big list earlier. This is what target blood pressure feels are the most common sources of error during blood pressure measurement. You see the wrong size cuff, cuff over the clothing, improper positioning, no rest when the patient gets into the office, picking the wrong arm or doing a wrist measurement, talking to the patient or the patient talking to you, deflating the cuff too fast. And then some of the patient factors, like I talked about a little bit, the full bladder, taking stimulants, nicotine, caffeine, recent exercise, or even eating, talking, texting, reading while you're taking the blood pressure. And then you have the environmental factors, location of the blood pressure monitor, noise, workflow, where it's at, how the patient's sitting, and everything. So the impact of the inaccurate blood pressure measurements, as I said, you can make a false diagnosis or you can miss a patient that truly has hypertension. And a problem with blood pressure is the variability exists in everyone, and it contributes to an uncertainty about whether a single measurement of blood pressure is representative of what a patient's true blood pressure is. And so the uncertainty about the true blood pressure is a big reason that clinicians fail to initiate therapy or to escalate therapy in patients who aren't meeting their goals for blood pressure. And studies have shown that conventional or routine office blood pressure measurements tend to correlate poorly with what the patient's true blood pressure and future cardiovascular risk events are. And the poorly performed blood pressure measurements, which are very common, result in the inaccurate blood pressure. So everything here taken together puts a lot of uncertainty into what the patient's blood pressure really is. And as I said, if we misdiagnose the patient's hypertension, say they're fine, or we don't treat them adequately, then that will contribute to potential harm to them over time. So if we look a little bit about the impact of the clinical setting on blood pressure, almost every patient will have some degree of, they call it the alerting response in a clinical setting. And those are two different things. One is white coat hypertension. They get a little bit stressed, have a little bit of anatomic response, and we get a high blood pressure when they're at home. If you put a blood pressure monitor on them, they would be fine. And some people, though, have the opposite effect. They come into the office and, I sort of think about this. Maybe they have a hectic life and they get into office and relax, and all of a sudden their blood pressure goes down. And so this makes it, again, difficult to judge what the blood pressure of the patient is when they're walking around and going about their daily activities. So the conventional office blood pressure measurements are our regular sphygmomanometer with the cuff, either mercury or most people have the aneroid, and where you manually use your stethoscopes. So it's convenient, inexpensive, but you have to have a good observer, a good technician taking the test, and it's more influenced by patient and environmental factors. And many offices aren't set up for proper positioning. We'll go over this a little bit more on how to properly position the patient. And it takes a little bit of time to do it effectively. And again, we can't rule out white coat hypertension or mask hypertension. Just reemphasize here, they found that it's rarely performed correctly in a doctor's office. So hopefully we can help address that. And so there seems to be a push towards there is a push towards automated blood pressure devices. So the 2014 guidelines in the International Society of Hypertension and the American Society of Hypertension, they say that electronic devices are preferred, that it's more reproducible and is not influenced by variation in technique as much as the manual method. And the 2017 American College of Cardiology and American Heart Association guideline also says to use a blood pressure measurement device that has been validated and ensure that it is calibrated periodically. So the automated office blood pressure device, like you see that they're automated, so you can actually program them to take 3 blood pressure measurements, and you can set the time interval between the measurements, 1 to 2 minutes, and then they average those measurements. So this will help minimize the white coat effect or the masking effect, because you leave the room, let the machine take the measurements and average it, and you come back in 6 minutes or whatever you have the machine set up for an interval between the measurements. But the big con for us is it's expensive, and then waiting the 6 minutes for the measurements to be taken. One of the problems that you run into is, how do you know your automated blood pressure device is good? And so that's one of the projects that the American Medical Association and American Heart Association is working on right now. They're developing a list of validated blood pressure monitors to help give us a starting point on picking out a device to use in our office. So Canada has a list of blood pressure devices that they have for being validated, and you can have the website right there. But Medival is sort of like consumers' safety product seal of approval on blood pressure on medical devices. The manufacturers pay them and they test them and certify them. And so they say that the Canadian list is not quite accurate because some of the machines on it are validated and say they are good when they're actually just a